Okay, now I'd like to invite Tafadzwa Kalisto Munzwa, the co-founder and the executive director of Dawa Health in Zambia. Today, he will be talking about the preliminary finding on AI-driven non-invasive anemia detection using a smartphone application. Welcome, Tafadzwa.
Thank you for having me, Katja. And good afternoon, good morning, everyone, depending where you're calling me from. I think I can just go on into how we've been using Baby Checker really in our mobile clinics and now also in slum communities where we still have a lot of challenges with regards to accessibility of diagnostic technology and how we really have been leveraging AI, including Baby Checker and other tools we have incorporated in our work and research as well. Next slide, please. Yeah, okay. Dawa Health is a company we started about 4 years back now. And the initial spark to the work we are doing now was my cousin at the time. So you can see that in low and middle income countries, this problem is really non-selective in who it affects. So my cousin at the time had a bit of pregnancy complications, which eventually resolved her, and her baby and herself were eventually stable. But that was the initial spark. And with my background training, which is medicine, I started really thinking around how could we use technology and innovative ways to reach more patients or more people like my cousin and to make a difference in their lives. So we have built that over the years and we've incorporated and evolved over time, which I'll briefly talk about, and also the tools we're using at the moment. Next slide, please. So this is a big problem or colossal challenge I decided to dedicate my life to, which is reducing maternal mortality in sub-Saharan Africa. So if you look globally, about 70% of the daily maternal mortality in the world happens in low and middle income countries, and sub-Saharan Africa is massively affected with that. So this is just a comparative analysis of, you can see the maternal mortality per 100,000 women across sub-Saharan Africa and across Europe. You can see, the significant difference that more than 533 mothers are dying, from preventable pregnancy complications in sub-Saharan Africa compared to just about 6 in Europe, which really emphasizes on finding innovative ways that can make a difference in life-saving going forward across our region, with what's been done before, not really solving it to the extent we want it to. Next slide, please. So this is the current state of maternal health in Zambia. And like I mentioned, about 70% of maternal mortality is still in sub-Saharan Africa. And in the markets we are working in right now across Zambia and Zimbabwe, you see that about 15 mothers are dying daily from preventable pregnancy complications, which is totally unacceptable. That someone would die from, example, postpartum hemorrhage, which could have been prevented with the right screening tools, which I think Baby Checker does to a significant extent, and some of the tools we are doing. And another challenge we got to see in these communities we are working in is that most patients or most mothers present for antenatal pretty late. So they're usually coming in the second trimester around the 5th or the 6th month, which is usually later than we want them to. As health workers, we want a mother to come in the first trimester because that's when you can significantly make a difference and advise them or do the necessary interventions to prevent a complication setting in. And from what we were doing early on, maybe from the last 2 years, we got to see that even though about 40% of the patients receive antenatal, it's still not significant enough. And I think like what Enya alluded to earlier on, most mothers, you find that they've never had a scan before, and this is their 4th pregnancy. And you're like, how is that possible that someone is able to, have so many children and not have quality antenatal? So antenatal is still pretty significantly poor, even if, part of the population are receiving it, which is some of the problems we want to address. And we have a lot of undiagnosed high-risk patients from things like low-lying placenta, which is what we call placenta previa medically, to things like anemia in pregnancy. These are some of the risk factors that can be intervened early on and correctly and to prevent complications setting in. But most patients go to delivery without that being done, and possibly explains why we still significantly have high mortality rates in our region. And one also issue of the current system or health system in Sub-Saharan Africa, Zambia to be specific, I don't know other setups, is you usually have your clinic or your hospital dedicating a single day in a week where they call it an antenatal week. So you find that that day might not be comfortable or flexible for every mother to come in. And also just generally how the attitude of the health workers is still a challenge. So those are some of the challenges that still exist, in these setups, which we're hoping to address, incorporating our model and innovative tools like the baby checker going forward. Next slide, please. So the solution we've built at Dawa Health over the last 2 years or so is an integrated, holistically approach to maternal health. So we have internally built a tool that helps us identify the necessary, parameters when talking about maternal health. So it looks at things like past medical history, takes a look things like the observations that have been done, demographics, a number of things, and using that data, we're able to kind of predict potential risk. Then that then goes on to the mobile clinic vans we have. So they go into the communities usually where you don't even have a local clinic, and we're able to partner with either local pharmacies or markets there. Then patients are coming into the mobile clinic for a comprehensive maternal, interventional support. So in the mobile clinic, that's where you have tools like the baby checker that are supplementing our internal house, a predictive platform. And with this, we're able to kind of give a comprehensive support to maternal health, identify high-risk patients. If they need early referral, we refer them to advanced centers where the appropriate intervention can be done. And we supplement this by a network of community health workers. So in the communities you operate in, you have local custodians who have the social capital, who are trusted, who've been in these communities for a very long time, that are able to mobilize patients to come in to access services at Dawa Health, making it useful, right? Because a tool like Baby Checker would need the patients to come in and seek the healthcare. But we see that in low and middle income countries, it's more than just the diagnostic tools, it's even the attitude and behaviors. So we're trying to also tap into that and, kind of champion people seeking healthcare early and getting the right healthcare, which has significantly, in our pilot over the last year, we've been working with Baby Checker, reduced the average first antenatal point of contact from about 6 months to between 1 month and 2 months, which makes a significant difference in us allowing us to support and identify potentially high-risk mothers in intervening time. Additionally, we've added on a hybrid pharmacy that enable us to retail things like your folic acid, vitamins that might be needed during pregnancy to supplement a mother, providing the right nutrition and, right oxygen to the baby. And lastly, we are also essentially incorporating last mile logistics. At the moment, we have a network of motorbikes that deliver these things to our community of workers. Next slide, please. So this is essentially just a summary of how the whole concept works at the moment. So we essentially onboard community healthcare workers who we then give training on how to mobilize the population, on how to essentially tell them about Baby Checker, the advantages it comes with, and the other tools we incorporated, and where they can find us through our mobile clinic vans, through our partner slum clinics as well. Then we're able to essentially do the needful triage and essentially support the mother accordingly and rightly. Next slide, please. So these are some of the tools we are currently using in our mobile clinic vans and in our model. So we are using the Baby Checker powered by Delft. So with this, we're able to potentially identify some of the high-risk mothers, and we've been able to identify a number of them. And the outcome have been good because of that early detection. We've also additionally added a Gen II tool into our channels, which is WhatsApp, mobile app, and web. This allows mothers to access the right validated medical knowledge in their native language because it's able to do interpretation between languages. and we're able to also now do anemia detection, which is part of the tool I'll talk about in addition to DELST. That's essentially looking at the conjunctiva. Then it's able to approximate the hemoglobin levels and how that essentially help us manage patients who are potentially high risk, adding to what baby checker would be able to identify. Then we're also doing a predictive algorithm on our platform, which has been supported mainly by MIT Solve, which I talked about earlier on. Next slide, please. So I'll go into this case study. One of the interesting case study we recently had. So we operate in a number of slum communities in Zambia at the moment, and one of them is Ngombe, which is a significantly underdeveloped area, but with high population density. And you find that you have a lot of teenage pregnancies, and a lot of high risk pregnancies in that area. So we had a female 23-year-old who came. She was around 36 weeks, 3 days at the time. She had our first point of contact with our team. And we were able to essentially look at how big the superficial frontal height was, about 36 centimeters. We did the BP profile, which is around 128 to 78 millimeters of mercury, and pulse was around 82 beats per minute. So if you see, before we had incorporated baby checker, if you see such a patient, as a health worker, you'd assume everything is okay, and you'd send such a patient back home, not knowing that she's even a potentially high-risk patient. Then when she goes to her local clinic to deliver, you find that this patient would likely bleed on the table and potentially die. Why? Because their placenta is low. This is something as clinical or as health workers, we're not able to tell clinically. But with such a tool like Baby Check, as you can see our team here using it, we were able to identify that this patient had a potentially low-lying placenta, which is what I said, placenta previa. So placenta previa, essentially, when the baby is coming out through the birth canal, they're essentially able to cause trauma to the placenta, which would cause excessive bleeding, and a patient can die from that bleeding. So you can see that with a tool like Baby Checker, we were able to pick that early on, and we were able to know that this is not a case you can manage at a low-level health clinic. So we referred this patient to a teaching hospital where they were able to be assisted, and the mother was able to be stabilized, and the baby was delivered, and the baby was okay. At the score of 8/10 under the first minute, the 9/10 under 5 minutes. So you can significantly see how in the real world a tool like Baby Check is actually making a difference, because we're able to identify some of these potentially high-risk patients who would otherwise maybe succumb to whatever undiagnosed conditions they have. And a tool like this would help in the management and early referrals and really make a difference in the last mile. You go on to the next slide. Yeah, so AI-powered non-invasive anemia detection tool, which is supplementing the work we're doing with Baby Checker. You will see that some of the patients who succumb to what we call postpartum hemorrhage is essentially any blood loss that happens during giving birth that would essentially lead to hemodynamic instability, or essentially someone going into shock, what we call medical shock. So you can see that a placenta like Baby Checker helps us identify before it happens. Then a tool like the non-invasive anemia detection enables us to identify the level of the blood in a patient before they actually go for delivery. So with this, we're able to see that about 80% of the patients in our early access pilot were anemic. So essentially they had blood levels that were lower than what we medically recommend. And when patients give birth, they're likely to go into shock. This might be even with placenta previa, with other conditions. So such a tool is helping us really comprehensively support a patient, that we might be able to see, okay, the low-lying placenta is not there in Baby Checker, but this is a patient who has low blood. So even if they give birth at their local clinic, there's minimum bleeding on giving birth regardless, right? So that can still cause a patient to go into shock. So these such tools that are AI are kind of comprehensively helping our clinicians in the last mile make the right clinical decision to say, okay, with this, we're able to refer this patient, we're not able to support such a patient. So that's how significantly AI is really making a difference in the last mile and making a change in the communities we are operating in. You can go on to the next slide. Yeah, so this is essentially just going a bit into some of the research we've been doing in-house, some of it with Delft, some of it with other partners, which is essentially trying to just improve the AI long-term. So this table was just, we were doing a comparative analysis between, the non-invasive anemia detection tool and the standardized lab test to help us build into that data set, which eventually, have good clinical outcomes. So you can go on to the next slide. Yeah, so this statistical analysis was just essentially looking at some of the hypotheses we have to say, okay, where is AI at the moment, especially for the non-invasive anemia detection, comparing the mean differences between, the AI one and the lab standard, so that we continuously improve using the pictures we are capturing from, the smartphones or the non-invasive to make it significantly be good. So as you can see, I'll just summarize this. There's still more work that needs to be put in to make some of these tools really clinically significant, which is essentially what Delft also talked about, the research they're really doing on the ground to really make these tools validated and clinically significant so that they can be scaled to people who otherwise before didn't have any screening or diagnostic tools. Yeah, so this is just a summary of that. Next slide, please. Yeah, so this is essentially the question we've been asking ourselves internally. How can we really improve tools like the baby checker, tools like the NIADA, to really be at par with some of the clinical tools, and that can be scaled at large scale. So the recommendations we have decided to stand on with my team is we need more interventional studies or clinical trials, which we're already doing at Dawa Health, to really improve such tools that when they can be scaled, they'll be accessible to more people because they'll have validated work in such environments, in such setups. We've really also been looking at how can some of the model can be recalibrated. What are some of the challenges in making these tools be accurate or be at par with big expensive tools at the hospital setups. We've been also trying to look at bias analysis, which is a challenge with AI tools, of course. How can we reduce bias in terms of the data sets being built and collaborating with partners like Delft? We hope that would significantly improve, the data set to have, representative of, the population or the communities we are trying to scale these tools in. And also we are hoping to have explainability on how AI tools will understand some of the results and make a difference. So yeah, this is essentially, our recommendation as we are building in-house and also with different partners. You can go on to the next slide. Yeah, so this is the impact so far we've been able to currently have significantly in the communities through the partnerships we have with companies like Delft, with the baby checker and other partners as well. We've supported over 7,000 patients already, and we are significantly trying to scale this by end of 2025 to between 20,000 to 30,000, which will really make a difference in making such tools accessible, help reducing some of the complications like postpartum hemorrhage, things like preeclampsia and other things. Some of the things I touched upon them earlier on. I can go on to the next slide. So this is some of the testimonials we are getting from patients who have benefited from Baby Checker and the model we've essentially developed. So they're really loving the difference such scans make. So you find out that one way patients are now referring to Dawa Health is the place where you have multiple tests done. So they love the Baby Checker too. They're saying this is a really advanced tool. Why don't other facilities have them? So that's the kind of brand identity people are starting to identify us with, and the extension of our community healthcare workers. So you can really see people now being motivated to come in for antenatal checks, to come in for support and all that, which really at the end of the day will translate into the impact going forward. We can go on to the next slide. So essentially I'll ask in case, of course, on the panel, there are people who want to partner with us. to do collaborative research to improve continual testing, improving AI tools in low and middle income countries, and also partners who might want to support research, whether in terms of funding, in terms of expertise and all that. We're definitely hoping we can continue building this work, which will really make a significant difference in low and middle income countries in a couple of years when such tools are scaled at large and it's more accessible and making a difference in our communities. Next slide, please. Yeah, so essentially this is my team I've been working with over the last 2 to 4 years, helping us make some of the differences. I just wanted to appreciate them, that people see the amazing people who've been behind this work, and some of our research collaborators as well, who are helping us champion this work in the low and middle income countries like Zambia and Zimbabwe going forward. Next slide, please. Yeah, so in a summary, I think that's it. Thank you, everyone, for paying attention and listening to the work we're doing, working with Delft and trying to scale this work of maternal health and accessible AI in the last mile. Thank you so much.
Thank you, Dr. Munzwa. Dawa Health's work in Zambia is truly phenomenal. A kind reminder to all our audience members today, please make sure that you write your questions in the Q&A section so that our experts can answer it at the end of the webinar. Also, to all our speakers, we truly welcome you to this webinar. We would really like if you continue presenting like this.